So happy that you could join us. As always, we would love, love, love to have two people to discuss with us and a case presenter. So if you have any case that you would like to present, please let us know. Hey, if you ask me, any case is a good learning case. So don't be shy. And yeah, put your names in the chat. In the meantime, the one and only Robbie Jiha is going to reflect. I'm sure it's going to be awesome.
Oh, well, that's very, very kind. I'm looking at my my background. It looks fake, doesn't it? Like, look at those clouds. Well, actually, you don't see them anymore. Wait, hold on. Let's get you those clouds. Oof, I can't do it. Okay, I have an offer. I'm going to pose a question to the chat, and the first person who responds after I pose the question with an answer. There are many answers. If you are willing to respond in the chat, that means you're willing to discuss the case. So. If you are a CP Solvers team member, please don't respond. If you have a case, please volunteer to present it. And if you're willing to discuss, please jump on the chat with the following question. Yesterday, Steph and Zaman co-discussed an amazing case that the one and only Gabrielle, who I'm really hoping will have a response to this question, therefore be forced to discuss, forced in quotes, featured many things. But one thing I wanted to reflect on, because I think we haven't reflected on it yet, is what it means to have an apical predominant infiltrate. So yesterday's case is multidimensional. I will leave for you to reflect on it, but one aspect of it actually I think was very, very helpful is an infiltrate that is apically predominant. So we usually do this on Twitter where we build schemas together and one of the CP Solvers folks starts us off. So instead of starting us off, I would love for you to name a cause that results in an apical infiltrate. And the consequence of you jumping into the chat is that you'll have to discuss. So go. I will pull up a schema for it. I won't reveal the schema until we build most of it. So please, if you can think of a cause of an apical infiltrate and are willing to discuss with us today, jump on in the chat. In the meantime, I am going to work on getting the schema ready. So what causes an apical pulmonary infiltrate? The mysterious apices of the lungs. Wow, I'm staring at the chat. Nothing, dead silence. Nobody knows nothing no more. Nobody knows nothing. Apical pulmonary. Mario, hello. Good noon, good afternoon. My first discussant, Mario, thank you for volunteering to discuss. It is an honor and a pleasure to discuss with you again. That is 100% correct. Mycobacteria, all mycobacterial diseases have a propensity to affect the upper lobes. A Pancoast tumor is a fascinating syndrome that describes any pulmonary tumor that actually originates at the upper lobes, though there is no propensity for it. But I love that thought. So Mario, thank you for volunteering to discuss today. Who else can think of another cause of an apical infiltrate? Whose resistance will break at the price of awkward, pseudo-awkward silence? Apical pulmonary infiltrates. Help Mario out, people. Yeah, you won the lottery. You know, true that, my friend. I feel like I won the lottery because I get to discuss with you. All right, y'all, come on, you can do this. What causes an apical pulmonary infiltrate? Mario gave us a great example of how an exogenous cause, something from the world, can do it. Can you all think of any endogenous causes of apical pulmonary infiltrates? Sarcoidosis. Travis Smith, CP Solvers team member, gets a freebie.
I knew it was free. That's why I jumped in.
Right? Yes, sarcoidosis. Can you think of anything else? Come on, team. Charmaine, how bad is your bite? We have Tarek. No way. Amazing. Tarek, please unmute yourself. Introduce yourself to the VMR crew. Please.
Hi, my name is Tarek. I'm from Manchester, the UK. I'm a medical trainee here.
Amazing. It's a pleasure to see you. Is there any way you can turn your video on? If that's not possible, no worries at all.
My laptop webcam doesn't work, and I can't stay for too long because the United AC Milan game starts in 25 minutes.
I feel you. That's totally okay. Stick around for as much as you can. As a diehard Manchester United fan, I completely understand. In fact, look what I have open on my phone. Let me show you. Let me show you what I have on my phone, my dear friend. Look, you see that? See that? Right there with you. Right there with you. Would you mind discussing the first half of the case? Is that okay?
Yeah, I'll try and stick around for a bit.
All right, wonderful. Your answer is spot on. Klebsiella also has a propensity to affect the upper lobes. Who has a case? All right. In the meantime, I will leave you all with a prompt for somebody to have a case for our dear friend Tarek to discuss before he watches Man United destroy AC Milan. Yes, destroy. Here is what I have. I think it's absolutely fascinating to reflect on diseases that have a propensity to affect the upper lobes. And it's helpful to think about them as diseases that originate from the world, that take over the upper lobes, or things that are actually from within the body. And there are a whole variety of infections that have a propensity for the upper lobe. The prominent are mycobacterial diseases and pneumocystis. There are a lot of organic material that can make it into the lungs that has a propensity for the upper lobe. All the pneumoconioses except asbestosis, all of them. But asbestosis, curiously enough, has a propensity for the lower lobes. Some other organic material, ABPA and hypersensitive pneumonitis, and a couple of smoking-related lung diseases can do it. And here's your list of endogenous causes. There's some that are really rare. They're not worth remembering, but as Travis pointed out, sarcoidosis has a propensity for the upper lobes. Cystic fibrosis, curiously enough, affects the right upper lobe universally in all patients. There's something about the right upper lobe that cystic fibrosis really affects. And the HLA-associated diseases, so spondyloarthropathies, have a propensity for the upper lobe. So how is this helpful? Yesterday, we had Gabrielle presented a case of a patient with a right upper lobe infiltrate, and the upper lobe propensity was really marked. And I think the priority in any case is to prioritize infectious causes. And I think in that case, it turned out to be one of those 2 infectious causes that you saw. So I would say take advantage of not only what the pathology is and infiltrate, but where it is. And in the upper lobe, think infections, organic material, and smoking-related diseases as common exogenous causes, and the most common endogenous cause is sarcoidosis and cystic fibrosis. So thank you, Mario, and thank you, Tarek, for playing a little bit of a game. I don't think we have a case presenter yet. Maybe we can go for another minute.
Oh, okay.
Open it up to questions or clarifications about that, and wait for a case.
Oh. Okay. I just want to congratulate Tarek for having such great taste in soccer. Because as soon as you said Manchester, I was like, "Ooh, I hope he's a United fan, not a City fan."
And there, I put a tutorial in the chat about why cystic fibrosis patients have more severe in the upper lobes.
Amazing.
I think it was maybe from a year ago, but it's on there from my Med Tutorials account. So enjoy that one. That's good.
Thanks so much, Travis. All right, y'all, who has a case? We literally cannot do this without you. Oh, man. Thai tea.
How's your tea, Robbie?
Oh, just so good. It's Thai tea. It's supposed to be iced, but I have it warm. And the key is 1 Splenda. 1, just 1. And it's just heavenly. I can sit here in the sun, hang out with these wonderful people all day long. I'm going to guess the number 3 for the number of cups of coffee you had so far. Or 2. 2. Let me change it to 2.
I'm just working on my first one.
What? Holy cow. Today is
Contrary to popular belief, I don't have more than 1 or 2 cups a day.
Yeah, where does this popular belief come from? Do I just spread lies about you? Is that what happens?
It just takes me a long time to drink a cup of coffee.
Interesting. That's why it's always, I remember Charmaine when we used to work in the same building. Oh, Tarek has a case. Okay, cool. You know what? Go ahead. Jump on in and present it. We'll reflect on it, and maybe we can turn it into, I know you have to leave soon, so we can reflect on it and turn it into some conversation afterwards. All right, so Mario, Charmaine, and I, we can jump in, discuss this case, and Tarek, thank you for offering to present.
Can I just get 2 minutes just to jot a few things down from memory, just to make it a bit more?
Of course yourself. In the meantime, Mario, please unmute yourself, reintroduce yourself to the VMR crew, and maybe tell us a clinical pearl that you learned in the last week or so that you want to reflect on?
Hey, hi everyone. My name is Mario. I'm a 6th-year med student from Lima, Peru. That's like the equivalent for I think a 3rd-year med student in the States. And I have a reflection, or well, not a reflection, but a doubt that I kept from yesterday's case. I had in my mind like a disseminated TB infection, especially like from a pulmonary source, as having a miliary pattern, like a lot of very small nodules on a chest X-ray. And yesterday's case, it was a consolidation. So I remember thinking, okay, probably it's less probable to be a disseminated TB infection. So something that I realized, I think, is that TB really presents in any way, shape, or form. And I think there are certain patterns that help us, but usually you can get, because it's a so common disease, especially for example Peru, it can be common to have uncommon presentations.
Well, I think that's a brilliant reflection, and I think that the term miliary TB is fascinating because it implies that TB has spread hematogenously to the lungs. So you're right that when you see a miliary pattern, the likelihood of extrapulmonary disease is through the roof. But TB can start in the lung and disseminate elsewhere without disseminating to the rest of the lungs. And I think that's what you saw yesterday. You saw a focal evidence of TB pneumonia, but then it disseminated everywhere. But sometimes it can also disseminate back to where it came from, which is this crazy paradox. And that's why you see the nodules everywhere, because the lung has now become a site of metastatic infection. But you can totally have lung TB disseminate to other places without disseminating to the lungs themselves, which is kind of crazy, but definitely very real. Yeah, thank you for sharing that reflection. Tarek, are you good to go?
Yeah, I'm good to go now.
All right, let's rock and roll.
So aliquot 1, if I've got that right. So this is a 92-year-old lady who was admitted with a few months history of reduced exercise tolerance, a general functional decline, and worsening shortness of breath over the last few weeks. So that case happened in 2020, March 2020.
Terrific. Maybe I'll ask Mario and Charmaine to kick off the first aliquot. This is a great set of information. Thank you.
Yeah, thanks so much, Tarek. Mario, well, what do you make of the information so far?
Okay, so this is an old female patient that comes with what really takes my attention here is a shortness of breath that I translate to dyspnea. And I've learned from Ravi that the prevalence of disease makes us think almost all cases of shortness of breath are from a cardiopulmonary source. So I would be looking for signs and symptoms that localize to the pulmonary or the cardiovascular system. And in terms of etiologies that I would be thinking here, I think Tariq mentioned March. So probably, and I assume it's in the UK. I'm not sure if the COVID pandemic started in that time in the UK. I'm not sure.
Yeah, you're correct.
Okay, so that's something to keep in mind, especially being this a high-risk patient because of the age. Besides that, we'll be looking for a history of if this patient had cardiovascular risk factors in terms of heart failure, decompensated heart failure, or other common types. Is there a history of tobacco use, for example, thinking of COPD exacerbation or something like that? That will be would I be prioritizing right now?
Mario, that was absolutely brilliant, my friend. I love that you were incorporating the base state of disease. So thinking about shortness of breath and dyspnea, we often think about the dyspnea pyramid, and the base of it, which is the biggest portion of it, it tends to be the pulmonary and then the cardiovascular etiologies of dyspnea. And I love also your thoughts about like, okay, I see the shortness of breath, so broad differential, then I want to know what else the patient is experiencing to help narrow that schema a little bit more. I thought that was very fabulously done. She's 92 years old, which means she's 92 years young and full of wisdom and medical history. So I would also be curious to know what is this patient's background, as you were alluding to, Mario, and hopefully that would also help us signal, put this shortness of breath in the context of who this patient is. So, with people who have lived a full life, they've also experienced a lot. So thinking about, hey, like, what is exercise intolerance to this 92-year-old? Is it the person who walks 5 miles a day? Is this the person that only at baseline like walks to the bathroom and back? So establishing like the degree of the dysfunction that and suffering that she's experiencing is always very informative to like also think about like the urgency of it, and like how fast you need to address this, and just get to know the patient's experience a little bit more. In terms of like the shortness of breath, with the dyspnea in general, like I always like first want to think about the no misdiagnoses, which also centers both in the pulmonary and cardiac etiologies, especially in some, as people get older, they can more likely present atypically. If this patient had an ACS event, is this, a downstream effect of an acute process that she experienced atypically a few months ago, like pulmonary embolism, someone if she's elderly and not moving around as much. So I tend to always, like, when I see a patient, kind of like think about like, what are my misdiagnoses for dyspnea? And then, you can also borrow it from Robbie's chest pain, 4+2+2. Not so much the esophageal causes, but the pulmonary and the cardiac etiologies remain. So I think getting a little bit more information about who this patient is, the time course is interesting. It's been going on for a few months. So we know this is not something that came on acutely. So that could also give us a little bit of time to think about like subacute processes. You mentioned heart failure, in the times of COVID, you mentioned COVID, that's all great. So before like delving more into the schema, I think the next round of information will be informative to figuring out which route we want to go into.
Sure. So her baseline is she used to live alone. She mobilizes with a frame. She's predominantly housebound. And her family does support and care for her quite a lot. But in the last few weeks prior to admission, she's had to move into her daughter's house because she's finding it increasingly hard to do things on her own, including getting about. In terms of her past medical history, she's got type 2 diabetes, which is diet controlled. She's got hypertension, and she's got ischemic heart disease with a PCI to her left main stem and her LAD just 12 months prior to admission. And she's also a non-smoker. And I'll give you the medications as well. So past medical history, ACS 1 year ago, treated with PCI to her left main stem. Her medication includes aspirin, clopidogrel, bisoprolol, ramipril, 20 milligrams of oral furosemide, simvastatin, 40 milligrams, and amlodipine, 5 milligrams. She has no known drug allergies, and she doesn't drink any alcohol and no recreational drugs, not that we knew of either.
Amazing, Tarek. Thank you so much. I know you have to leave in a little bit, so maybe I can just share some small reflections on this aliquot and ask.
Fine, I'll stick around for a bit. Don't worry.
Okay. All right. Terrific. Thank you. I'll reflect a little bit on this aliquot, then have Mario and Charmine tackle the exam, the rest. And I'll say that I think if you look at the responses in the chat, you can make a lot of inferences. Rafa said stable angina-aortic stenosis, and William said anemia, and all those are subacute to chronic diseases. And I think it's a marker of the presence of exercise intolerance before the dyspnea tells you that you're dealing with a subacute to chronic cause of dyspnea. Most people who have a hyperacute cause of shortness of breath will proceed rapidly through the exercise intolerance phase and jump into the shortness of breath phase. So pay attention to that. If somebody's telling you that they first noticed a reduction in exercise tolerance followed by shortness of breath, that tells you that the cardiopulmonary disease that you're likely dealing with began slowly and progressed slowly, like aortic stenosis, like stable angina, like anemia. That is very informative. And the history is as expected. Ischemic heart disease and diabetes are very common in older adults, and the medication regimen that she's on is appropriate for that. And the key question is this complication related to her ischemic heart disease, either recurrent ischemia or complications to the heart from ischemia, like valvular disease? And then, you have to step back and be like, am I too focused on cardiopulmonary disease processes? Could this be the rare, less common possibility of GI bleed from aspirin clopidogrel, or could this be even rarer cause of simvastatin causing some sort of myopathy? So I think the lay of the land is as laid by Mario and Charmine. Is this a cardiopulmonary disease process driven by her medical conditions, or is this a complication of therapy with aspirin and clopidogrel raising the possibility of GI bleed and simvastatin potentially as a cause of myopathy? Just of note, there's a smaller risk of the combination of simvastatin and amlodipine, a slightly increased risk of myopathy than simvastatin alone. So that combo in particular might elevate that risk. But I'll hand the mic back to you, Tarek, for more data.
Yeah, so just at this point, in the week prior to her being admitted, she also had a CT scan, a CT of her thorax, abdomen, and pelvis for recent weight loss. And the result of this was cardiomegaly, generalized anasarca, and bilateral pleural effusions, worse on the right, but no obvious malignancies. I'm just going to give you some vitals, if that's okay. So she was apyrexial. Sorry, we tend to use degrees Celsius here rather than Fahrenheit, but afebrile. Heart rate was 90 beats per minute. Her resp rate was 25 per minute. And she was saturating 89% on room air. In terms of a general examination, she was a very frail and cachectic looking lady. She had significant muscle wasting and sarcopenia. Her chest had bilateral crackles at the bases and reduced air entry at the bases. Heart sounds were normal. Abdomen was soft, non-tender, but there was some shifting dullness indicative of ascites. Neurologically, she was intact. And she had bilateral peripheral edema, lower limb edema to the thighs.
And sorry, Tarek, was that a shifting dullness to, sorry, I didn't hear that part.
So she had some ascites.
Great. Thank you so much, Tarek. Mario, what are your thoughts? Now we have more information and this awesome exam.
Yes, I have one question. Do we have the jugular venous pressure tracing, or was there any findings there?
JVP was not raised.
Not raised. Okay, so I think the first thing that comes to my mind is we have risk factor for heart failure. We have a prior CT with revealed edema and bilateral, I think, pleural effusions, and the exam that confirms that. So the first thing that comes to mind is this is heart failure. The only thing that could be a good differential is, especially with the ascites and the lack of and the JVP not being raised, would be a chronic hepatopathy like cirrhosis. But I'm not sure what's the negative predictive value of a normal JVP in this case, because the patient has what appears to be congestion, but also hypoperfusion because of the history of being cachectic, losing muscle, and sarcopenia. So I think right now, my working diagnosis would be heart failure with, I think the classic phenotypes are saying it is warm or cold, dry, or wet. This would be a wet and cold, because we have signs of congestion and hypoperfusion. And adding the fact that maybe we should look a little more detail into maybe any type of liver pathology, primary liver pathology, like hepatic cirrhosis, not cardiac, that could be caused also by this working diagnosis of heart failure.
Beautiful. Thanks so much, Mario. And yeah, you're absolutely right. This patient appears volume overloaded. And, you know, given that a cardiac history of someone who has multiple coronary artery risk factors, she has coronary artery disease risk factor within ACS that was treated about a year ago with stents, with like ischemic cardiomyopathy being a very common etiology of heart failure. It's a great thought. Yeah, and I think like you're absolutely right for that normal JVP to give you pause, because it is a dipstick to the heart, and if it's normal, then it should absolutely give you a pause. And I'm always, a JVP for me is still something that I'm working on and trying to get better. So I'm always open to the possibility that if I'm looking at a JVP and I don't see it, it might be my technique. And sometimes like people have such elevated JVPs that, you know, you have to look at about their ears to see it because they're so volume overloaded. However, I totally agree that like with her symptomatology, heart failure is something to consider. Whenever I think of volume overload similar to you, I think of three organs, like the heart that we talked about. I think of the liver, and then I think of the kidneys. And when it comes to the exam, like we talked about the JVP being a good marker for heart failure. With cirrhosis, as you mentioned, absolutely, it can give you pleural effusions, it can give you ascites, hypoxemia, all of the symptomatology that we are seeing here. With cirrhosis, it also leaves traces on exam, especially with signs of hyperestrogenemia. So thinking about if this is a person who has pulmonary erythema, a gynecomastia, which is like in a woman is a lot harder to recognize. Telangiectasias. So you want to look for capillary medusa, or anything that would help you point towards not just like signs of hyperestrogenemia with cirrhosis, but also complications of cirrhosis with portal hypertension being the one. But in terms of being more specific to help you distinguish between cirrhosis and heart failure and kidney disease, then signs of hyperestrogemia tends to be the most specific to cirrhosis. Lastly, the kidneys. You know, the kidneys, I love the kidneys. I feel like they never get as much credit in the world where we focus a lot on the liver and the heart. But, you know, when the heart is in distress or the liver is in distress, the kidneys can be at distress too. But primary kidney failure can also cause evidence of a hypervolemia. And it might not give, and the exam might be very unremarkable. Sometimes like with nephrotic syndrome per se, that can cause a significant amount of anasarca. People tend to have more facial edema as well, upper extremity edema that you sometimes don't see as much with other etiologies of hypervolemia, which we don't see here. But those are the three organs that I will evaluate, like getting an echo to get a sense of the cardiac function, getting liver chemistry, synthetic function to think about cirrhosis, knowing that a 92-year-old with catectic, she most likely have a low albumin to begin with. So kind of adjusting your pretest probability for cirrhosis based on who this patient is and what she's been experiencing over the past few years, and also getting your creatinine and your kidney function test to see if there's anything there for you to worry about. And in the meantime, you know, just symptomatically treating her to get her feeling better.
So a bit more information. So in terms of bloods, her full blood count was pretty much unremarkable. There was no rise in her white cell and she was not anemic. Her sodium was 129. Her potassium was 4.5. Chloride was normal. Phosphate, magnesium, calcium, I can't remember off the top of my head, but it was nothing particularly exciting. Her creatinine and urea, again, I don't have the exact values, but for the sake of the discussion, we'll say it was about in the range of a CKD stage 2. Her AST, ALT, bilirubin and gamma GT were all unremarkable, but her albumin was 22. She had a chest X-ray which showed bilateral pleural effusions, worse on the right. And she had an ECG which was in sinus rhythm with some anterolateral Q waves. We also had an echo not long from her ACS, which was just a year ago, and that showed moderate LV impairment with an ejection fraction of 45%. So that was the last echo we had on our system.
Can you repeat the echo, please?
Moderate LV impairment, ejection fraction 40 to 45%. And we treated this lady initially as a acute decompensation of her heart failure with IV furosemide. And she had sort of transferred to the cardiology unit where I was working at that point. Her COVID test was also unremarkable, well, negative.
Tarik, this is super helpful. I'll say that I'll share a very brief reflection, then ask you to give some more data for the dream team here, which is that I think if you say this is a patient with a history of heart failure who comes in, who is anosarchic, no matter what else you say, the priority should be on decompensated heart failure. And the one thing that throws a wrench in that hypothesis is the presence of weight loss. So the vast majority of patients with heart failure will gain weight. So how do we marry those two? Can you have heart failure and weight loss? Absolutely. There are some rare causes, but the most common cause is what's called cardiac cachexia. And that's when you have advanced decompensated heart failure from long-standing disease that causes you to waste more muscle than you gain fluid. So the math is not that you have not gained weight because of the fluid retention. It's that you've lost so much more muscle mass because of the end-stage nature of your disease. More morbidly, though, is a malignant pericardial effusion, where the malignant process drives so much weight loss that it overcomes the amount of weight gain that comes from the heart failure. There are 3 other rare causes to keep in mind: hyperthyroidism, thiamine deficiency, and endocarditis. None of which seem to be at play here, except the possibility of thiamine deficiency. We've ruled out a pericardial effusion through cross-sectional imaging. The possibility of cardiac cachexia is very notable here in a 92-year-old patient who has sarcopenia. But the possibility of untreated hyperthyroidism and untreated thiamine deficiency are things to consider. But if you are entering the world of heart failure and weight loss, you have to entertain the possibility that your diagnosis is incorrect, that in fact you have a mimicker of heart failure. The most notorious mimicker of heart failure is nephrotic syndrome. It looks exactly like it, and it's very, very evasive. And what is your ever-present clue for nephrotic syndrome? It's hypoalbuminemia. So to summarize, if somebody has a history of heart failure and presents with volume overload, it's heart failure until proven otherwise. What moves the needle towards otherwise? Weight loss. Is weight loss incompatible with heart failure? Absolutely not. Think cardiac cachexia and pericardial effusion as the most common causes. But you have to think, what else could it be? And nephrotic syndrome is your most likely mimicker. And that the support for nephrotic syndrome is augmented by the hypoalbuminemia. What else could low albumin be caused from? Well, the problem is that low albumin can really occur for any reason. Any inflammation can cause a reduction in albumin synthesis. Liver disease can also result in albumin synthesis. And in addition to losing it in the urine by virtue of nephrotic syndrome, sometimes you can lose it in the GI tract or in the vessels. Here is a quick glance at an approach to low albumin. Most common causes are that you don't make enough of it, usually because of inflammation or liver disease, but you lose it through kidney, the GI tract, or through vessels. I think here, I'll hand the screen back. But here, I think you're in the world of, is this heart failure with weight loss, or is the albumin to the clue that the urinalysis will reveal proteinuria? And I think that's the key question. And that's the humbling part about the patient's diabetes is, she's already at risk for getting nephrotic range proteinuria from diabetes as one potential cause of nephrotic syndrome. So she has a risk for it, and she has a reason to entertain that possibility. All right, Tarek, back to you.
I really like that you mentioned that, because I was on the consultant ward round. He normally comes 3 times a week, and I'd seen the patient the day before. And he says, Tarek, have you done a urine dipstick on that patient? And I said no. So I disappointed him many times prior to this, and again on this occasion. So after the ward round, we do a urine dipstick, and it shows protein plus. We send it for a urine protein creatinine ratio, which was in the high thousands. And we even did a 24-hour protein collection on this lady, and it came back at 16 grams of protein loss in 24 hours.
Wow, fascinating. That was an awesome discussion, Robbie. And Tarek, what a great case. Mario, what are your thoughts?
Well, I think when we mentioned the three main buckets of a peripheral edema: heart failure, cirrhosis, or a kidney issue in especially nephrotic syndrome. I think that remains true, because I think as Ravi said, if you're thinking heart failure, we should think also on the other 2 buckets. Did we get the echo? The echo did reveal like a cardiovascular impairment. So could this be? I would bet this would be like a mixed picture of a heart failure and a nephrotic syndrome. And I think it's really important to get the dipstick and the urine protein got sent, because otherwise maybe this patient would never have gotten that diagnosis. And I think she isn't on the appropriate medication to prevent or at least to slow down the diabetic nephropathy. We're assuming this is diabetic nephropathy, so I think that's important. And the other point, I was thinking about the hyponatremia, and I remember 3 buckets for hypervolemia with low effective circulating volume that can give you an increased ADH and therefore a hyponatremia. And that's heart failure, cirrhosis, and nephrotic syndrome. So I think that's also consistent with that. And yeah, those are my thoughts.
And thank you for sharing those thoughts. I love it, Maria. I mean, this patient has heart failure too. So the question is like, what is the kidneys doing that like further exacerbate the volume overload that she's experiencing, right? So you're absolutely right that this is a patient that's going to continue to get optimization for her cardiac risk factors and also her heart failure, in addition to trying to figure out why is this patient has nephrotic syndrome and what can we do to better characterize that to hopefully be able to prevent her. Because you're absolutely right, like symptomatically she's going to get diuresed, but is there anything more that we can do? And when it comes to nephrotic syndrome, you're absolutely right that diabetic nephropathy in someone who has a history of diabetes is something to be considered. There are also like other etiologies that I think of, usually like in adults, membranous membranous nephropathy tends to be a common etiology of nephrotic syndrome. Often it's primary is more common and secondary, and sometimes with primary you can, if I think about like, okay, if I'm working this up, Kidney biopsy would be great, but 92-year-old, would they do a kidney biopsy or not? So you can send a serology. I think it's like PLA2R something serology that tends to be positive in 80% of people with primary membranous nephropathy. And that tends to be more. That also tends to be a chronic. It also increases the risk of thrombosis as well. The other one that I think about is FSGS, that is like more subacute. And then also in all of these like nephrotic type syndromes, like both FSGS and also membranous, that both primary processes are more common than secondary. Like from step one, like you think of like HIV as cause of FSGS, which is not this patient. And the other thing that's less likely that we see more in adults is kind of like minimal change disease, which is less common in adult population. And then there are also like rare causes like amyloidosis, IgA that can do it too. So their list is broad. So I think whatever I can do serologically to help find an answer in addition to a nephrology consult would be helpful. But you're absolutely right that a 92-year-old with nephrotic syndrome, diabetic nephropathy is the one that we think most about. But, membranous is something that I would think about in her too. So I'm like curious to see what Tarek did to help get to the bottom of this. Before that, Robbie, any additional thoughts?
Nada, zero.
So yes, at this point, we had established that she's got nephrotic range proteinuria. And looking at history, we were, could this be secondary to her diabetes or hypertension, like you said? We got a nephrology consult. So just to give you guys the context, we don't have nephrology on site in our hospital. It's in a nearby site, so things are done via email referrals, and they don't have a visual assessment of the patient. And because of COVID, they were not doing in-reach consultations either. So that made the whole process quite complicated. I'm going to give you some of the results we had sent as part of the renal screen. So we did an HbA1c, which was 52. I don't know what values you normally use, but that was sort of slightly high. We started her, I can't remember what antihypoglycemic we started her on because of her renal function, but we'll move on from that. Her SPEP, PUPEP were fine. She had an anchor screen, her anti-dsDNA, her complement levels, Hep B, Hep C, HIV, and we sent a few other parts of the renal immunology, and all of that were unremarkable. There's one immunology that we've not sent, which I've not mentioned now, but I'm going to mention that after, and that would give the diagnosis. And all the results have come back negative. And at this point, she was on a 500 milligrams infusion, 24-hour infusion of furosemide with daily 5 milligrams of metalizone, and her weight had only started to shift then.
Tarek, you've really taught us how one, it is so difficult to control the disease process in patients with nephrotic syndrome. We'll talk about the diagnosis a lot, but it really is very hard to achieve euvolemia in these patients because it comes at a much higher risk of damaging the kidneys themselves, and is really, really a very, very hard job. And I commend you for doing it. I'll say one thing stood out to me is you said that you disappointed your supervisor, I think is the word to use. And I will say that I would say it seems to me like I have such little insight into that relationship, but it seems to me the kind of disappointment that a coach might have in somebody they're training, where the heaviness of the disappointment may not be admonishing or diminishing, but rather a disappointment that you'll share this case and learn from it and grow from it, and clearly you are. So I would say I see that word, and I suspect it's a healthy kind of disappointment. And if it isn't, I think a lot of us have that sense from our supervisors of trying to be perfect and feeling lesser when we aren't. But I thank you for being part of this community, because I think one thing that we try to do is to recognize how prevalent that feeling is and how important it is to acknowledge it and to recognize it really is an opportunity to learn rather than an opportunity to feel small. And so here, my friend, you start off by telling me that you are watching the menu game. So you're already enormous in my mind. And now your psychological size is through the roof, teaching us a lot from this case and some of the parts that were probably a little bit difficult for you in the moment. For me, my learning point is the following. When you think about nephrotic syndrome, when somebody says the words nephrotic syndrome to you, what tends to happen is a mumbo jumbo of alphabets. Minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis. And that to me tells me everything I need to know. Nephrotic syndrome is a histological based disease. We talk about it based on the histology, which tells you that a large fraction of patients need biopsy. What does that also tell you? It also tells you the disease tends to be centered on the kidney. Unlike nephritic syndrome, which is inflammation that usually is systemic, nephrotic syndrome tends to only affect the kidney, which is why you only can get to biopsy the kidney. That's the problem. Okay, so what do you need to know about nephrotic syndrome? It's an alphabet soup of histological analyses. Why? Two reasons. One, it usually only affects the kidney and affects the kidney in a manner that unfortunately we require biopsy. But the landscape has changed a little bit with the ability to diagnose primary membranous nephropathy with serology. And what Charmaine was mentioning, the phospholipase A2 receptor, is very sensitive and very specific for primary membranous nephropathy. It is one of the best biomarkers we know. Why? It's sensitive, it's specific, and it correlates with disease activity. So you can track it, and it will start to increase if your patient's disease is recurring. So it's really a phenomenal biomarker. So in addition to that, what chance do you stand at not biopsying the kidneys for nephrotic syndrome? It is potentially diagnosing lupus, potentially diagnosing hepatitis B or syphilis, and potentially diagnosing amyloidosis through SPEP, serum free light chain. But in all those situations, we often end up with a kidney biopsy for staging of disease and understanding extent of disease. So it's very hard not to biopsy kidneys in this patient. You probably would avoid that. And what serological chance do you stand at not biopsying the kidney? It's probably, practically speaking, only the phospholipase A2 receptor. But here's the lay of the land. This is nephrotic syndrome in a simple form. It's much more complicated than this. Membranous, most of it is primary. FSGS, most of it is primary. Minimal change, most of it is primary. Good luck. You have to biopsy the kidney. But in membranous, you can get away with getting this receptor and you're done. But here you see there are secondary causes from infections, cancers, autoimmune diseases, HIV, as Charmaine mentioned, and cancer. So I'll pass the mic back to you, Tarek, to take us home. And I'm glad to hear that a serological test answered was the answer in this case for the patient.
Yeah, you made some really excellent points there. So there was a lot of back and forth with the renal team whether or not to biopsy this lady because she was 92. Her English was very limited. I did not mention this earlier, but there was some question regarding some mild dementia in her, and it would involve taking her to a different hospital, and also the fact she was on dual antiplatelet therapy with clopidogrel, and the cardiologists were not too happy with stopping that with a big stent in her left main stem. So finally, eventually, her PLA2R antibody came back very highly positive, and that kind of helped clinch the diagnosis for the renal team. So she ended up with a diagnosis of suspected primary membranous nephropathy. Interestingly enough, I've moved to that renal team, and I checked up on this lady's follow-up this year, and she was started on cyclosporin not too long ago, but unfortunately she passed away with COVID 2 weeks ago. But I thought it was a really humbling case because we fell into the trap of everything looked like heart failure. She had all the perfect combination of comorbidities to be treated as heart failure. And we just put the albumin down to, oh, she was cachectic, she was probably not eating very well, she had poor nutrition, and embarrassingly, I forgot to dipstick her urine. So that's the one thing I learned from that case is always look at the albumin and always dipstick the urine.
Tarek, Thank you so much for sharing this case. I learned a lot. And, I love humbling cases. I have experienced many of them. And I think it's needed in medicine. And I think it's hard to go through medicine and not get humbled. Um, and I- and I think what helps me is that kind of the mentality that Robbie always talks about, like having a growth mindset is, what we can do from, this type of cases that like maybe the diagnosis is a little bit delayed. Maybe we're suffering from diagnostic error or uncertainty. Is that like we will just better equipped to serve our patients next time we see them. And nephrotic syndrome is complicated, as Robin mentioned. It can really mimic heart failure. So kudos to you for sharing and for helping us all become better diagnosticians, better doctors. And I'm sorry to hear that this patient passed away, and I'm really grateful that she got such a great care from all of you, and that we get to benefit from her life story too. So thank you so much for sharing. It means a lot.
No worries, it was great. Thank you.
And hope Manchester United wins today.
Wishful thinking given their current football form, but let's hope so.
I still have hope after all of these years.
I will confirm they are not losing.
Good, nice. Mario, Robbie, any additional thoughts before we pass on to Gurleen for?
I just want to say I for the first time heard Mario's translation of his 6-year student to the U.S. equivalent. I'm shocked, quite honestly. I thought 6-year student meant that he is graduating or something near the end. Because honestly, Mario, your discussion, your level of conversation is incredible. And I will say, I only speak for myself, as way more eloquent and thoughtful and rich than I ever was when I was as a 6-year equivalent student in Peru. So thank you for your brilliant reflection and for volunteering to discuss. And I hope others can see how much growth and learning happens, and will be inspired to rock back and forth in their computer chair with you next time.
No,
We're
thank
such a
you, Robbie.
fan
Thank
of
you.
you.
I mean,
We're such a big fan of you, Mario. Can't wait to discuss next time.
The fan. I'm the biggest. I'm the fan, not the other way around. I wanted to thank Tariq. I think I have catch myself so much time during this case, like just pivoting on a piece of data that I shouldn't have, and I think that's the only way to learn is to discuss cases, and I'm sure I will learn from all the teaching points, for example, during the dipstick, and those are learning experiences that I've just learned from Tariq. So thank you very much.
Great case.
What better way to end than Gurleen? Take us away.
Yeah.
By the way, to tell you, Gurleen is matching next week. So send her all the love in the world, all of it.
Thank you. So this case started off with a case of dyspnea. So when we're thinking about dyspnea, we think about the Dyspnea Pyramid, so the base rate of disease. So the most common things would be pulmonary or cardiovascular. But if we're trying to look deeper into other things that can cause dyspnea, we can think of it anatomically. So when we're thinking anatomically for the cardiovascular system, we're thinking about the myocardium, the pericardium, and the electrical system of the heart. So myocardium, we're thinking about things like heart failure, coronary artery disease. With pericardium, thinking of constrictive pericarditis or tamponade physiology. With electrical, thinking of any arrhythmias that could be causing dyspnea. And we're thinking about pulmonary causes. Again, anatomically, we can divide it up into the airways, the parenchyma, the alveoli, or the vasculature. And then besides the pulmonary and cardiovascular systems, also thinking about if the dyspnea can be due to chest wall disorders, neuromuscular disorders, or other hematologic things such as anemia, which can cause dyspnea, or other things like acidosis or thyroid abnormalities. And then in this patient specifically, the dyspnea was more subacute in that it wasn't an acute onset, but it was going on for a couple of months. So that helps us figure out what might be the underlying cause. And as Robbie mentioned, having the fact that exercise tolerance developed first and then the dyspnea came on kind of suggests a subacute nature as opposed to an acute cause. And then when we're thinking and framing this patient, when we're approaching it, we're trying to figure out who is this patient, what are their risk factors, what is their baseline functioning in terms of what does the decrease in exercise tolerance really mean? And then we're thinking about her in terms of she has cardiovascular disease risk factors, which does predispose to cardiac etiology. So you still have to keep other things in mind. And the other aspect was that the albumin was low. And when we're thinking about this patient who's older, might not be having the right nutritional environment, she might have a low albumin to begin with. So keeping that in mind when we're approaching the lab values. The other aspect as we progress through the case is the volume overload. So when we're thinking about volume overload, we think of 3 different organs. We think about the heart, we think about the liver, and we think about the kidney. With liver, you can see other things on physical exam or other things on labs that might suggest a liver pathology. So if there were features of hyperestrogenism or pulmonary erythema or telangiectasias. And then in the kidneys, as Charmaine mentioned, upper extremity edema, like in the face area, would be more common, but definitely doesn't always have to be the case as we saw in this patient. And then when we're approaching edema overall or lower extremity edema, we can think of it as pitting versus non-pitting. And then when we're thinking about pitting, you can break it pathophysiologically based on, is it due to increase in hydrostatic pressure or is it due to decrease in oncotic pressure? So when we're thinking about an increase in hydrostatic pressure, that could be because you have too much fluid there or you have too much pressure. So too much fluid could be because of a cardiovascular cause or a liver cause. So cardiovascularly, you're having a decrease in the ability of the heart to pump. So you're not able to distribute it around the body, so it builds up. And then the other aspect would be if you have a decrease in resistance, such as in liver pathology, you have a decrease in systemic vascular resistance. So your body thinks that you don't have enough blood volume circulating in your body and you have increase in your renin-angiotensin-aldosterone system. So the pathophysiology can help us think about different causes, but decreased oncotic pressure, we commonly think of nephrotic syndrome, but other things to keep in mind would be if you have decreased protein absorption through the GI tract, through like a GI protein losing enteropathy. And then in terms of this patient, the clues that we were specifically focusing on was the edema and the volume overload, but then this patient had cachexia. So when we usually think of heart failure and volume overload, we usually think of weight gain, but there are some causes that you can have cachexia, such as pericardial effusions that are malignant or thiamine deficiencies or hyperthyroidism. So that really made us reframe our hypothesis because everything was lining up to sound like heart failure given the comorbidities and the things that were found. But that diagnosis might not be correct given the fact that there was cachexia, and that helped just kind of reframe and think of what other things could be causing it. And then looking at other things, and the other clues was the low albumin, and similar things can cause low albumin, as we mentioned. For the low albumin can lead to an increase in volume because if you have decreased oncotic pressure and decreased Starling forces. And then finally, we came to the diagnosis of nephrotic syndrome. So when we're thinking about nephrotic syndrome, the most common causes would be things like diabetes and hypertension. Other aspects would be membranous nephropathy, which can be both primary and secondary. So primary, as I learned today that I didn't know about, was the phospholipase A2 receptor, and that's what ultimately ended up being the diagnosis. But when we're thinking about kidney things in general, usually the biopsy does help guide the diagnosis, but sometimes serologies and other things, like in this case, can help pinpoint what's going on.
It's amazing. Remember to keep us posted next week, okay? Bye, y'all. See you tomorrow.